session on Bempedoic Acid, and the topic is Bempedoic Acid in Uncontrolled LDLc, Unlocking Concept and Unleash Efficacy. For this, we have our renowned speaker, who is a well-known cardiologist, Dr. J.S. Hiremath sir. Dr. Jagdish S. Hiremath sir. He is Director, Cath Lab, Ruby Hall Clinic, Chair Professor, Preventive Cardiology, MUHS, Chief Cardiologist, Heart Transplant Program, Ruby Hall Clinic, Pune, teacher for DM and DNB for 10 years. So, with this, first of all, I would like to welcome our esteemed speaker, Dr. Jagdish sir, on this platform. And without wasting much of the time, I would request sir to please take over this scientific session. So, welcome sir once again.
Thank you, Dr. Abhijit. Am I audible?
Yes, sir, you are clear and loud.
The treatment of lipids have been undergoing a lot of changes. So as time goes by, I think those who are old timers like me, when we started practice, there were no statins at all in the market. And from there on, we went on to develop more understanding related to lipids, the causal effect of the lipids on atherosclerosis, and the concept of, the good cholesterol, HDL, and other things slowly went away. All the trials related to high HDL failed. All the drugs which elevated HDL failed. So finally, it boiled down to one bad cholesterol, that is LDLc. And that is what we are aiming at today as a linear relationship with development of atherosclerosis. A new kid on the block is the bempedoic acid, especially when uncontrolled LDLc happens despite a good doses of statin or the best doses of statin. That means sometimes the doses are not tolerated. So whatever is best tolerated at times without statin, it can be used. So today I welcome you all for this session. It will last for about 40 minutes. I'll deliberate on the LDL as a molecule causing atherosclerosis, the available options, and a special emphasis on bempedoic acid. So the principal clinical manifestations of atherosclerosis are well known: the cerebrovascular accident, the myocardial infarctions, and ischemic heart disease, transient ischemic attacks, unstable angina, peripheral vascular disease, and of course, aortic aneurysm and aortic valve disease. We all are quite familiar with this atherosclerotic plaque, which is said to be vulnerable, rupture prone, because this is the atheroma, this is the lumen of the coronary artery, and the cap is very thin because it can rupture anytime. There is inflammation under the surface of the endothelium because of macrophages and T lymphocytes, mast cells. They are trying to combat something, and the combat is due to this lipid crystal. This is a new development in the field. Cholesterol actually is there in the form of crystals, and the macrophages are trying to engulf those crystals, and that is where the war starts and inflammation sets in and atheroma ruptures and acute coronary syndrome happens. We know that these cholesterol crystals are nothing but LDL finally, and that's why dyslipidemia always a major concern in cardiovascular events, irrespective of whether it is a primary prevention or secondary prevention. A large trial where a lot of Indians were involved, published by Salim Yusuf in Lancet in 2004, showed that irrespective of a large number, more than 15,000 patients, and amongst all the risk factors, lipidemia remained a major risk factor. And almost in 90% of the patient, these risk factors existed. Starting from there, we know a very interesting slide. And these are the LDL values on the x-axis, 50 to 60, 60 to 70, right up to 160. And here are the bars. The brown bar here is no atherosclerosis. And the blue bar is the worst form of atherosclerosis. So if you see between 50 and 60, probably there is no atherosclerosis. But even in the so-called normal values of 70 onwards, there is evidence of subclinical atherosclerosis. Here it is subclinical, but beyond that, it is actually manifestation of the disease. So if you aim at LDL below 70 or maybe below 60, that is where you form no atherosclerosis. A child is born with a LDL level of 30. So we know that we need to control all this atheroma. And in the cardiovascular outcome trials that we have, long number, a FOREST trial with simvastatin, HPS trial, prove it what pravastatin, TNT was atorvastatin, improve with Jupiter, and all these trials ultimately show that a chain of evidence consistent with LDL causality in atherosclerotic cardiovascular disease. So that is the chief culprit. We need to target that and we need to hit it hard so that we prevent diseases from occurring first time or the second time. And epidemiological data of United States very clearly shows that a total cardiovascular disease, diseases of the heart, coronary disease, and strokes all have been going down, down, and down since about 1970. That is where the advent of statins occurred. So statins have played a major role in public safety related to cardiovascular disease. It has proven to be better than aspirin as far as prevention is considered. And there are a large number of trials all of you are very familiar with. You don't have to look at the trial. It just says that primary prevention of trials of statin. And in this, a large trial was the Jupiter trial of primary prevention. It said that those who got 50% reduction of their LDL levels got less than 57% relief from cardiovascular events. So it's a very startling, major, bold statement to make. But what about the other statement? In fact, if you look at this carefully, almost 50%, only 46% got the reduction of more than 50%, but 42% were less than 50%. Management of LDL. They have helped us. They are wonderful, but still something needs to happen more in order to prevent, reduce the LDL. And the secondary prevention of trial of statins, if you see all of them, you're probably all familiar. They all targeted LDL to be lower and lower and lower. So FOREST trial, which said high LDL is bad. Then they said average is not good. Then they said lower is good. Then the Improve It trial says that even lower is even better. And the Fourier related to PCSK9 said lowest is the best. So ultimately what we are looking at is targeting the LDL lower and lower and lower. Lower the LDL, lower is the events, and there is a linear relationship between the two. In fact, to look at it more lightly, it's like the modern day genes. Lower you better, the wear it better. I don't want to comment on this picture so much, but I hope you understand that lower is better. So the concept of LDL casualty in the pathophysiology of atherosclerotic vascular disease was understood. Concept of cumulative arterial LDL cholesterol burden, like if it starts from very early age, it's going to cause more damage. The concept that lower LDL is better, and the concept that very low LDLC may be even better. And the concept that earlier start reduction, the latter it may be more optimal. That something can be yet debated. But up to the fourth line, I think we are all concurrent on this. So when you come to management of dyslipidemias of high priority of statins and first line therapy agent, but there are concerns. Concern number one is, do all statin users achieve the LDLC goals as per guideline recommendation? And I don't know where we went. Something jumped. Okay. Okay. Here is the guideline continued recommendation of LDL targets. Way back in 1988, the target was less than 130. 1993, it became 100. Slowly over a period of 200, 2010, the target getting lower and lower. And now it is at the lowest level. The Lipid Association of India marks the goals as 100 for a almost normal individual or a little high risk individual, 55 for a high-risk individual and 30 for a very, very high-risk individual. So it's all getting lower and lower. And this all stemmed by this 2017 guidelines, 2019 guidelines of the European Society of Cardiology, which they said that a low risk person can be up to 116 LDL. And then we are not discussing total cholesterol, triglycerides, HDL, only LDL. So here we talk of, say, somebody moderate risk can be below 100. That means a few risk factors or age above 60 would be this category. High risk group, that means somebody who has major atherosclerotic cardiovascular disease, family history, high LDL, all these things would be LDL has to go below 70. And very high risk, that means multiple vascular fields involved, multiple times has been admitted, this group goes to below 40. That means somebody who is already on statin, but yet develops acute coronary event, he goes down to less than 40. And of course, LAI goal I mentioned, corollary to that would be almost done. And very, very high risk would be less than 40. So we know that all LDL levels are going down. Then we were believing, and we were made to believe, that Indian dyslipidemia is different. Central obesity, the 4 quartet Indian spinners all had probably central obesity even then. And the mahol was that spinners is India, and India, even they go abroad, they will start bowling with spinners. But things have changed. Young India is different. Modern day problems are different. We are also getting almost like the Western outfits, smaller waistlines, and we do exactly the things what are done. And so are the LDL values. Yes, it is important that triglycerides had been looked at. Central obesity is our health problem, but LDL is the primary cause of concern, and we should be now reorienting, rethinking ourselves to target LDL as low as possible. So based on the revised ESC guidelines, how many patients are controlled under LDLC? Da Vinci score study was one such study, which was a real world study in which there were almost 6,000 participants, primary prevention 3,000, secondary prevention 2,008. And if you see all participants, if you take, then as per the revised guidelines, only 27% were eligible patients who were receiving high intensity statin. So not many were receiving high intensity statin. And 33% of those who got the high intensity statin were to the target. That means you can look at this column. They required high intensity statin, but only 27% got it. And those who got it, only 33% were exactly controlled to the LDL values that we just discussed. And those who were very high risk patients, in those also only 37% were receiving high dose statin and 18% were on the desired level. That means if somebody's desired level is 40, you have given them the best, highest dose of statin, but still only 18% will get the desired level. So obviously there is an unmet need of something more than just the statins. So there was this Korean study which also reiterated the same, that if you have a correct high dose and in lower levels of LDL, that means if you have a LDLC which is less than 70, and if it is reduced less than 50% to the original value, these are the people who do the best. That means we need to do this. Lower 50% of the original definitely, and lower below 70, and absolutely to 55 very high risk individuals. So the concern too with statin treatment is how to achieve LDLC targets after the maximum tolerated dose of statins are used. Say, I don't know how many of us use 80 milligrams of atorvastatin or a 40 milligram rosuvastatin, but suppose you use it, and if the LDL is still not at target, then what do we do? And we saw that alarming number of them would be not at target. So if you look at the moderate intensity statins, say about 10 to 20 of atorvastatin, 5 to 10 of rosuvastatin, and 2 to 4 of pitavastatin, it would reduce the LDL by 30%. High intensity statin, 40 to 80 of atorvastatin and 20 to 40 of rosuvastatin would reduce the LDL to less than 50%. High intensity statin with ezetimibe, additional 15% benefit. PCSK9 inhibitor like evolocumab, which is available in India today, It on its own reduces 60%, with high intensity statin 75%, and high intensity statin and ezetimibe would reduce it to 85%. So wonderful reduction is obtained when you have all three on board the polypharmacy for management of lipids. However, PCSK9 inhibitor is prohibitively expensive as of now, and that does not remain an option. It's like almost saying that Mercedes is a wonderful car, but how many Indians can afford a Mercedes is what we should think of. So that's why if we look at the polypharmacy today, ezetimibe prevents absorption of LDL from the intestine. Statins work on the liver and reduce the synthesis of LDL cholesterol, and PCSK9 inhibitor modify the receptor and lower the plasma LDLc interim. So three of them do at different sites and reduce the LDL levels in the plasma. And that is now the role of bempedoic acid, an ATP citrate lyase, that is ACL inhibitor, a first in its class LDL lowering drug, is the new kid on the block, and that is what we are going to study today. Bempedoic acid, the mechanism of action is that it blocks this ACSVL receptor. Bempedoic acid blocks that, and that's why conversion of citrate to HMG acetyl coenzyme A to HMG coenzyme A is blocked. At this site, actually, the statins work. So bempedoic acid actually works on the same axis, but about 2 steps before statins start acting. And the importance of this is that it will get expressed only in the liver. It doesn't get expressed in the skeletal muscles. And that's why bempedoic acid, being it's a prodrug, it has to be converted to bempedoic active form inside the liver. So its expression is inside the liver, not in the skeletal muscle. And that's why you do not get the muscle side effects which statins otherwise would get, because statin will have an action in the liver and also in the skeletal muscle. So that is the biggest difference between the two, that no skeletal muscle kind of side effects, which are, if you start looking at, there are many patients who get this. So basically statin intolerance can be overcome by this action of bempedoic acid. Prodrug has to be converted to active drug inside the liver, and the action will stay limited to the liver, not in the skeletal muscle. So in indications as of today, our approval year is not very long ago. It's used in uncontrolled LDLc. You have marked the LDL goal and it is not achieved by whatever dose of statin or ezetimibe or evolocumab that you have used. Maximum tolerated statin dose, mixed dyslipidemia, familial hypercholesterolemia, high-risk ASCVD patient, and statin intolerance, or whom statin is contraindicated for some reason. Maybe somebody has had a rhabdomyolysis in the past. These are the people who would be using 180 milligrams orally with or without food once a day of the bempedoic acid. The management who receiving the bempedoic, the half-life is 21 hours. So obviously, it's a once a day treatment. 70% excreted through the kidneys, 5% through the feces, and 2% unchanged through the kidneys again. So if somebody has a mild renal derangement, there is no need to alter the doses. In high dose, renal impairment, end-stage renal disease, it is still not studied. So it's true for hepatic dysfunction, mild abnormalities, it can be used, but high liver dysfunction, it should not be used, or let's say it's not studied. Then comes the concerns are over, becomes the monitoring level. All patients, because bempedoic acid will increase the uric acid and in fact can have manifest gout. So these are the patients who are clinically assess serum uric acid before you start bempedoic acid. Then for those with prior history of gout, you have to be cautious, not that it cannot be used, but you should be alert about the development of these things. Then if somebody has a problem related to more than 60 years of age, taking corticosteroids or other quinolines, renal failure, and history of tendon rupture in the past, this drug is warned and not to be used. Obviously, all these patients who are high risk for tendon ruptures and gout should be cautioned, and you may have to discontinue bempedoic acid if this happens to them while the patient is on this drug. So the trials related to bempedoic acid were of two types. The ones which were called the Clear Harmony and Clear Wisdom trials, almost 52 weeks trial, 1-year trials. They were all patients of atherosclerotic cardiovascular disease and familial heterogeneous hyperlipidemia. They were on statins. So they were on full dose of statins, and bempedoic acid was added to that for a maximally tolerated statin background therapy. And Clear Serenity and Clearly Tranquility, these are the two trials of shorter duration. They were in patients who were for primary prevention statin intolerance, not so seriously ill patient, but statins could not be used in them. So in those, it was used. So it can be added to statins. It can be used de novo without statin. And if you look at the Clear Harmony and Clear Wisdom reports, the number of patients were quite good. Duration was 52 weeks. All the patients were almost on statin. And efficacy endpoint was percentage reduction at a baseline and at 12 weeks and the safety endpoints anyway. So if you look at this, there was LDL reduction was 18% on top of what the statin had already achieved. Non-HDL reduction 13%, total cholesterol 11%, and apoprotein B. Now this is generally not reduced by anything. So apoprotein B reduction is an added advantage of bempedoic acid. Clear Wisdom study results says that compared to placebo on its own, that means when statin is not used, the reduction is quite good to the tune of 28% or so. That is what I'm talking about, 23%. So Clear Tranquility is that the trials where the patients were not on or a very low dose of statin, and they're also on standalone de novo, it showed very good result. Reduction of LDL was achieved with a significant comparison. When it was added to ezetimibe, so it was ezetimibe alone, bempedoic acid alone, and the combination reduction was about 36%. So if you combine it with ezetimibe, you would get a good reduction. And if at all statins are added already to it, then you would get an even better reduction of the LDL levels. The Clear Outcome is something which is going on, yet a global cardiovascular outcome trial, nearly 14,000 patients. They are getting enrolled, and they will be enrolled up to December 2022. It is compared with placebo for a patient who are first primary and secondary prevention patient with elevated LDL and with statin intolerance. So these patients will be taken into two parts, placebo and bempedoic acid, and that will give us what is actually the outcome related to this trial. In high-risk patients, it is mentioned. So does it reduce inflammatory markers? The answer is a clear yes. So some little pleiotropic effect can be seen. Pleiotropic effects are very difficult to digest, especially personally for me. So I would say that I will observe this, yes, that it reduces the CRP, and that is what some implication of that will be probably coming on later. So if you look at the pooled analysis of 4 phase 3 pivotal trials of adverse event of special interest, hyperuricemia is clearly more in bempedoic acid as compared to placebo, and the p-value is significant. Gout, manifest gout is also more with the p-value is significant, but all others like raised enzymes, anemia, tendon rupture, new onset worsening diabetes, all of them were almost equal with placebo. So the main things you have to watch for is a gout and tendon ruptures. These are, and fortunately, they are less than 1-digit complications of this new therapy. So in summary, if uncontrolled LDLc is a major risk for cardiovascular disease, statins are the first choice, no doubt, for any type of dyslipidemia as of today. Even after good use of high-dose statin, almost 70% of the patient would be not on target for LDL. Uncontrolled LDLc increases the residual CV risk by 60 to 70%. Bempedoic acid is the first of its class agent having unique action, and significant LDLC reduction up to 18% on top of full dose statin. It can be achieved. Safe in mild to moderate CKD patient, also safe in mild to moderate hepatic dysfunction, also hyperuricemia, gout, and maybe tendon rupture may have to be watched, is how we will summarize bempedoic acid. So right now, there are many agents which can be used in lipid management. Statin clearly remains number one, but there are some close seconds and which are approaching the finish line very quickly. So always the question is asked to me in many of the CMEs as to how do you plan? When do you think ezetimibe should get added, or when do you think PCSK9 should get added? So this is my arithmetic related to that, and it is from guidelines. First, ascertain your goal. Suppose your patient is a very high-risk patient. Suppose a person is a very high-risk person. He's had a myocardial infarction or a bypass surgery. I would think that secondary prevention high risk, his goal would be 55. Suppose he's a very, very high risk patient, 2-3 events, young age, diabetes, hypertension, multiple risk factors, I would feel his goal would be 40 or below. Suppose now I ascertain this goal for such an individual. And so let's take an example of somebody like this who's sitting on a LDL level of 120, which looks very innocuous. Suppose I use the best dose of statin on him, let's say 40 milligrams of rosuvastatin. I would reduce his LDL level to 50% of the original. That means from 120, he will come to 60, but he's still not 55 or below or 40. So that additional boost has to come from something else, because we know that the best dose of statin can reduce to 50% and the moderate dose can reduce to only 30%. So if and suppose I'm now using 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin, there is a good chance that the patient may not tolerate it because of various symptoms. Then what do? I add a ezetimibe to this patient. Suppose I add ezetimibe and I feel that it will be another 15-20%. And if it reaches my target calculation wise, then I'm happy with it. But I start this combination, and after 2 months of therapy, we feel that it is not enough to reach that LDL target, then one can add a bempedoic acid. If statins have been discontinued or have to be discontinued because of intolerance, rhabdomyolysis, hepatic dysfunction, so many other things, then start bempedoic acid with or without ezetimibe. Statin and bempedoic acid can be combined. PCSK9, inclisiran are in the pipeline. At present, injectable and very expensive, so we don't discuss about them in a day-to-day basis. But all in all, we are close to a fact that LDL shall get conquered soon in the years to come, because we have this polypharmacy. So we have statins, we have ezetimibe, we have PCSK9 inhibitors, we have bempedoic acid, and other things. All put together, we can conquer this. So it's almost like moving this huge boat. It has to move fast. It has to reach to the target. And for that, you need multiple hands. Alone cannot do this job, but a good teamwork can do this. So the combination of polypharmacy that we have for anti-lipids can bring us to LDL level very comfortably. So polypharmacy, we know it is there for hypertension. We know it's used for diabetes. And we know that for ischemic heart disease, heart failure, we have a polypharmacy. And now that polypharmacy also for lipids, it is also for LDL. Once you do them, use them, combine them effectively, your LDL goals will get conquered. So we are looking at a better future for all our cardiovascular patients, maybe for ourselves or families, by combining. Fortunately, it's not a very expensive molecule launched in India, thanks to our great pharma companies who do a lot of research, innovative things, and bring the molecules to our doors at a reasonable cost. If we do that, then we can give a good result to our patients who need this. Thank you. I stop here. We'll start with the discussions and maybe take on some questions.
So thank you, sir, for this elaborative as well as informative session. Now we'll move on to our question and answer sessions. We have some questions from the participants. So the first question is, how suitable will be bempedoic acid for Indian population when statin is the first choice for Indian dyslipidemia?
Yeah, we always said, or we still maintain, that statins are number one. As I said, suitability is definitely there. We have already been using it. It's been tried primarily in Indian patients. So there is no question of tolerance or anything. We have to add it judiciously in our patient. As I said, target your LDL, decide what is your LDL goal. Suppose the goal is 70. You have used a good dose of statin, it is still sitting on 90, or the statin is not tolerated very well. So in those cases, you have to add bempedoic acid. And by adding that, the booster dose or two together will bring the LDL levels to the desired level. Addition of ezetimibe is also option available. And as I said, slowly we'll start moving towards polypharmacy for lipid management.
So the next question is, can it be given with PCSK9 inhibitors, and what should be the expected results?
There are no studies related to this. Generally, PCSK9, when it is used, it reaches the LDL target definitely. So many times it is addition of that is not possible, but patients who are statin intolerant, in them rather than using PCSK9 alone, one could use bempedoic acid to start with and then add PCSK9 inhibition to it. I'm sure it will result because it is the same axis as statin. I don't see logically why it should have any problems, but at present there are no elaborate studies to indicate this point.
So sir, moving to next question. Next question is, if we have to prescribe bempedoic acid in hyperuricemia patients, then how frequently should we monitor uric acid level?
Yes, we should have a baseline. We should be treating that if it is clinically indicated for uric acid. But after you having secured a baseline level, and if patient is not on treatment or on treatment for uric acid, I would repeat first time 1 month later, second time 1 month later, and then I am satisfied, then every 6 months is good enough.
So sir, next is, as bempedoic acid reduces the new onset of diabetes, can it be suitable option for pre-diabetic patients also?
Yeah, I mean, no connection. Even if the new onset diabetes of statins is a little overhyped, so we are not concerned really about the new onset diabetes or not. We can use it in pre-diabetics definitely.
Next question is, sir, is there any guideline like ADA or ESC has mentioned this molecule, or it has mentioned any data regarding this bempedoic acid?
I showed you it is accepted by guidelines as right now treatment for high-risk individuals. So we should not start it very easily is what they want to show. Every guideline is always cautious to start with. And anyway, we are proposing, a proposition is the same, that you have a patient which cannot be managed well with statins. You are not happy with the statin treatment, either by way of not achieving the LDL goal or by way of intolerance. Then only you would add it. And when will it happen? When the patient is high risk, that means your LDL goal is very low. Suppose the LDL goal is 100. If the patient is sitting on 130 and a little dose here, little ezetimibe, it can control. So right now it is reserved for high risk patients and it shall be used for high risk patients. And as our expertise gets better, experience gets better, safety is established worldwide, I think more results come out, it will get then available for other treatments. Right now, keep it only for high-risk individuals. That is what I have shown in one of the slides. It was mentioned in the guidelines.
Yes. So sir, next question would be like, is there any contraindication for hepatic or renal patients?
Yes, it is. End-stage renal disease. say, let's say below 30 ml creatinine clearance. It's not studied, so should not be used. Hepatic dysfunction, grossly deranged, SGS, PT, SGOT level more than 3 times the normal, then it should not be used because it is not studied in those patients. So, but in mild moderate, it can be used for both. Even in pregnancies, it is said that if the person, if the benefit is going to be overwhelmingly important, then you may use in pregnancy. By and large, it is contraindicated. Even in breastfeeding patients, it is not contraindicated as such. Keep away as far as possible. But if you feel that lowering LDL or keeping the LDL low is more important for the lady, it can be used even in lactating mothers.
So, like we know that in patients who are uncontrolled, who have uncontrolled LDLc with statins, then we can start bempedoic acid. So, after how many, after what duration of time we can assess this lipid profile and come to the conclusion that we can use bempedoic acid?
Start your desired or calculated statin treatment along with ezetimibe if at all you feel so. Repeat the lipid values after 2 months. They say 6 to 8 weeks, but let's say to make it one statement, let's say 2 months, that is 8 weeks, and then decide whether it is attained or not. If not, then you can think of adding bempedoic acid.
So, and this molecule, and this can be used even for secondary prevention also, sir, right? If the patient is not being controlled on statins, then in secondary prevention also we can use bempedoic acid alone if the patient is intolerant to statins.
Absolutely. There are enough, I think I showed the clear ones, the Serenity and Tranquility trials, which were conducted on patients who were not on statin. They were intolerant, so statin could not be used. And this molecule was used standalone in these patients, and they showed up to 28% reduction of the LDL with this. So it is almost equal to statins in effect on LDL. So it can be used standalone. If need be, first choice should be statin as of today.
So, sir, we'll take one last question and then we'll close the session. So, and the next question is, what would be the expected reduction of LDLc if we combine bempedoic acid with ezetimibe? Is there any data regarding this?
Yes, I showed you the slide. It is 36% of the original value. So if you use only ezetimibe, there will be some reduction. Only bempedoic acid, some reduction. But you combine the two together, the values come down by 36% of the original. And of course, if statin is added to this, then it will be even a bigger reduction.
So, sir, with this, we have come to end of our today's session. First of all, I would like to thank you for sparing your time at this moment of late evening and giving us this informative session. So once again, thank you, sir. And I would also like to thank our participants who have made this session a very interactive session. So in future also, we will keep on coming up with this some innovative molecules and such informative activities. So with this, I would like to thank everyone, and we'll close for today. So good night, everyone. Good night, sir.